Our first session of the day will be on health and healthcare. We know that for people experiencing homelessness, housing is healthcare. Our next two speakers deliver healthcare in the traditional sense as well. Dr. Charlene Flash is the president and CEO of Avenue 360 Health and Wellness, an 8-site health system in Houston that provides cradle-to-grave care while addressing social determinants of health, such as housing instability, food insecurity, and racism. She is an infectious disease physician who holds faculty appointments at the University of Houston and at Baylor College of Medicine. Frances Isbell is the inaugural CEO of the Healthcare for the Homeless Houston, a federally qualified health center providing care for 8,500 people annually. She was instrumental in bringing together many community-based agencies, healthcare clinicians, educational institutions, and public organizations to forge a common strategic plan to effectively address the health needs of people experiencing homelessness. Will you please join me in welcoming Dr. Flash and Frances Isbell?
Here with the two of you there so we can hear you both. And here's clickers. This.
Yeah, this little guy here. And she said down is forward. Thank you.
Thank you. And I'm honored to be here with Dr. Flash. We go back just a little ways. One of the things that happened was when she took over Avenue 360, we had lunch plans on March the 15th, 2020. And so we didn't actually get to see each other in person for, I don't know, a year and a half later or whatever. So we're here to talk about health and health care within the homeless population. Down, down.
Why don't we just say, oh, did it work? Okay, good. It's a hard push.
Okay. Now our slides aren't up. Next. Okay, so one of the things that Dr. Flash and I wanted to do was kind of set the stage a little bit in terms of how does homelessness affect a person's health. So some of these statistics might be fairly shocking to you if you don't know a lot of this world. So the people who are experiencing homelessness have a mortality rate of between 3 and 6 times of people that are housed. The estimated lifespan is reduced by 13 to 32 years. Persons with serious mental illness die 29 years earlier. 54% report that homelessness was precipitated by a health crisis. Medical costs, many of you may have read the LA study that came out, I don't know, 12 years ago. That study indicates that medical costs account for 58 to 62% of the overall costs of someone who is homeless. They have 9 to 13 times more emergency department visits and 3 times more hospital days than people that are housed. Next slide. So I like the next 2 slides. Next slide, please. Because it gives you a really good visual, and I'm not sure how well I can see this. So the reddish are people that are in the general population, and good, I didn't think to bring that. And the kind of navy blue, I'm sorry, I've got it backwards. The navy blue are people that are in the general population, and the kind of wine color are people that are experiencing homelessness. I like it because it's a good visual. So you can see with high blood pressure, the difference between people who are housed and people who are not housed, the difference between diabetes, between housed and unhoused, hepatitis and HIV. You can hardly see the line in the general population. And then we've got this over 4% of the homeless population having HIV. So a much, much higher incidence. Next slide. And when we look at mental illness, then we begin to see an even greater disparity between people that are housed and people that are unhoused. Look at that depression. And of course, if one is experiencing homelessness, you would assume that there's going to be a very high prevalence of depression. But it's, to me, these slides are just startling when you look at the difference between people that are housed and people that are not housed. Next slide. Mental illness and physical illness is one of the leading causes of perpetuated homelessness, and that has been documented in study after study. Chronically homeless people, even within supportive housing, 73% have been diagnosed with chronic pain-related disorders. 64% have severe mental illness. 44% have hypertension. 24% hepatitis, 22% diabetes, and 81% substance abuse disorders. So again, just this great disparity between people that are housed and people that are not housed. Next slide. So I'm going to give just a brief overview of Healthcare for the Homeless Houston. Next slide. Our mission is to promote health, hope, and dignity for those affected by homelessness through accessible and comprehensive quality care. Next slide. So who do we serve? We serve people who are still literally on the streets, people in emergency shelters, which of course we have very few of anymore, people in temporary transitional housing, people that are temporarily doubled up. So we see people who are literally homeless, still on the streets. Our funding source, which is different than HUD, allows us to continue to see people in permanent supportive housing because our funding source doesn't consider people that are in permanent supportive housing unhomeless. I don't think there's that word. I don't think that's a word actually, but so we get to continue to see people that are in permanent supportive housing. The fastest growing patient population are people that are over 60. So what's happening in the general population is also happening in the homeless population as well, which is terrifying when we think about the needs of people that are over 60 and the complexities of people that are over 60. And 90% of the people that we see have no form of insurance. Next slide. So we have 3 different locations. Many of you know the Caroline Street location, which is our standalone clinic. That's right by St. Joseph Hospital. We have the Cathedral Clinic, which is located within or adjacent to the Beacon. And then we opened last year in the middle of a pandemic, we opened the Reed Family Clinic, which we're really excited about. That is located in the New Hope Reed location, and it serves families, including children. So that's really exciting. We're within 7 different permanent supportive housing sites. We provide street medicine, and also we provide the transportation project that many of you participate in, Project Access. Next slide. So our care model is an unusual care model that is becoming more and more common. We were the first agency here in Houston to implement what's called primary care integrated behavioral health. So what that means is that within the primary care setting, we have both psychiatrists and clinicians who only work within the clinic. So they work side by side with the primary care clinician. We do have longer term therapy and psychiatric services, but within the clinic, they are all located right there with the primary care clinician. And why do we do that? Because there's study after study that will indicate that if you get behavioral health care from your primary care clinician, you're going to be much more likely to be adherent to whatever treatment there is. Next slide. And then this slide just kind of reemphasizes what was discussed earlier, that we have a very collaborative model. We can't do what we do without collaborating with all of the other safety net providers here in town. Next slide. Across all of our programs, pre-pandemic, we see between 8,000 and 10,000 people a year. Next slide. And this I just like to show because it's so, the visual is so great. So we have at our Caroline Street Clinic, we have a 6 operatory dental clinic. Next slide. And look at the difference. Next slide. Yeah, isn't that great?
Slide. Thank you, Frances, and especially for those pictures. Sometimes pictures are worth 1,000 words. Before I start, I just want to say how exciting it is to be here alongside Frances and actually looking into all of your faces, not behind a Zoom camera. So many of you I've gotten to know over the past 2 years as I joined leadership at Avenue 360, but always with a filter on. And so it's amazing for us to actually be in the room together. And I think that's something to be celebrated. So I just wanted to take that moment as I felt it looking out at all of you, how amazing it is to be in a room with people. In any case, next slide. I wanted to take a moment to talk a little bit about Avenue 360 Health and Wellness. We are also a federally qualified health center. Our model allows us to prioritize people who are unstably housed or in public housing, but we take care of people from all walks of life. Our mission is to ensure that we engage communities. Oh, you went too fast. I want to go through the different pieces. Go back one. Thank you. That we engage communities in ways that are community-centered and are patient-centered. No one's turned away because of their inability to pay. We want to work not just on the treatment of disease, but also the prevention of illness. We believe that health isn't just the absence of hypertension or HIV or mental health disorder, that health is really what we all think of when we're having a healthy day, right? You have physical well-being, you have mental well-being, you have social well-being, and that housing is critically important to that. In fact, just feeling loved and supported is an important part of that. If you think about your own life, if you woke up this morning and you weren't able to have breakfast and your partner griped at you about the socks you left in front of the bathroom, and so you feeling a little frustrated about that, and you don't have a safe place to go home to, you may have no diagnoses and you may not feel whole and healthy. And so we think about health, we together think about health in a little bit of a different way as we recognize that the wraparound services sometimes are more important than the medication that's received or the diagnosis that's received if you don't help people through it. Next slide. So we recently updated our strategic plan, and so our new vision is to be the provider of choice. We want to be a space where people from all walks of life can come and can feel proud to receive care. So it's not that you're going and you're getting the indigent care, but you're getting excellent care, whether you are indigent or not. To do that, we have to partner with many of the people in this room in order to provide the things that we cannot provide. Partnership is of critical importance. Relationship is of critical importance to enable us to do this in Texas, which is the country in the United States with the highest rate of uninsured in the entire nation. So the bar that we have here in Houston of the healthcare need, it's almost this enormous crevasse of healthcare need, and it cannot be filled by healthcare providers alone. We need the support of all of these wraparound services to help people actually engage in full health. Next slide. Now, in terms of the services, we have 7 primary care clinics and we have 1 hospice. We provide great cradle to grave care, so pediatrics, adult medicine, OBGYN, dental services. You saw the amazing pictures of what a smile can do. Immunizations, therapy. We also recently are one of the first programs in the country to provide screening, brief intervention, referral, and treatment for people for substance abuse for all the clients across our entire 35-mile footprint. It's a very different model. Often we wait for the clinician and the patient to confess to each other that something's going on. We're going to take the model that's affirming and just ask everyone, and then provide the services and link them to those services. So very exciting. We also have some subspecialty elements that we provide, such as HIV care, which is near and dear to my own heart as an HIV provider. Next slide. So in recognizing that the healthcare services are only one element, a core element, one element of what we do, we have many other team members. We have housing case managers and community health workers that go out into the highways and byways, providing health education, but also linking individuals to care. We could not do what we do without those folks who are working outside of the clinic walls to ensure that people are engaged and navigated through the process. We also have case management and lab, radiology, screenings for STI and COVID. I don't want to say it aloud, because I don't want the numbers to go up. So COVID, substance use screening and treatment, as well as both Class A and Class D pharmacies to support people who are in need of medication. Next slide. Now, in terms of housing, Avenue 360 promotes housing stability for those unstably housed, and we provide assistance with housing and food access, transportation, mental health services, recovery services. We've for over 800 households, and that represents over 1,200 men, women, and children. The services range from things like housing for people with AIDS, to tenant-based rental assistance, to a variety of programs that all serve to stabilize this housing piece. And I see Melody, who's actually a really critical partner for us, as many of you are, in getting this done. Let's look at Todd from Court Furniture. I mean, so many partners that really make this possible for us. Next slide. Food insecurity is another of the core. There are many social determinants of health. We've identified a few that are really core to people doing well in Houston. And what we've noted is that food is a real challenge here, exacerbated by COVID's presence. I should always say COVID's presence. We were able to provide food for over 2,700 individuals and families. And again, key partnerships. So this was in partnership with the Houston Food Bank that we started to have Saturday food drives. And I'll tell you that we had the food drives and then COVID hit, and the food drives, the food would be gone in like an hour. And the lines were going out blocks for people just desperate to actually have sustenance. We also have 41 households participating in our health equity department who receive financial assistance as well. Next slide. Now, one of the programs that Francis and I work on together is called the Soar Program. I love gorgeous acronyms that sound amazing and that represent what they do, soaring. Through expansion from the Texas Department of Housing and Community Affairs, we are able to support the Social Security application process. And so that means for people who have been marginalized in so many ways, it can give them hope of access to funding. And because we are healthcare facilities, we can also facilitate some of the things that are uncovered as you're working with someone through that. We're actually working through the logistics of that right now, figuring out, well, how do we seamlessly get people into mental health screenings and physical health screenings so that you can support their application in the most robust way, and then get them the care they need as well when those items are identified. Next slide. So COVID, let's talk about COVID. So I think that to talk about health and homelessness in this particular season that we all are in, and not to talk about the enormous international elephant of COVID would be a misstep for us. I think that, Francis, you'll agree that COVID actually completely changed the ways in which we do business and the ways in which we provide health.
And it will continue.
Yes. So in many ways, COVID is one of the greatest scourges that some of us will have seen in our lifetimes in terms of both the health and financial and societal transformation impact that it has had. However, with each challenge is opportunity. And from the dregs of COVID came all types of creativity, as I had to ask myself, gosh, I have all these clinics. I literally joined the agency 3 months before COVID hit. And because I'm an infectious disease provider and I'm master in public health, like my first week, I said, there's this thing that I read about in Asia. Can you tell me what the plan is for preparation? And so a staff member hands me a paper, one sheet, and that was the COVID response plan. Thank you so much. Do you understand that this is going to impact every element of the way that we do business? I've never seen anything like this in my entire career. Go back, revisit the page plan. So then came back with a 10-page plan about the healthcare and da-da. I said, no, you don't understand. This is going to be crazy. It's going to take out staff. It's going to make people not want to come to the doctor. We're going to have to figure out how to keep people safe. It's airborne and 95s. So they said, Dr. Flash, do you just want to write it? I said, no, I don't want to write it, but let's partner together and get a robust plan. So we ended up with, I think it was 35-page plan. I had no imagining that COVID would be actually what it has been, right? I said, oh, we'll contain it within our country, if it comes. It's transformed how we do probably forevermore. But from that came creativity. I was a telemedicine naysayer in many ways. I'm a physician. I believe in touch. I want to put my stethoscope on you. I want to smell the cigarettes and say, oh, how many cigarettes did you smoke today? Right? I want to see when I walk into the room and you haven't gotten to the table and I help you on the table and I watch you get on with a challenge and I say, is your back hurting? And they say, oh yeah, I forgot to tell you, right? So the experience, the patient physician experience is an important part of the element, but clinicians were nervous. Patients were petrified. How do you provide care for people when they don't even want to get close to each other? Telemedicine became something that wasn't a, should we do this? It was, we absolutely must do this if we are going to care for this community, keep our team members safe and actually provide the care that they need. So part of the response though was, for the people in this room, likely telemedicine is no big deal. Most of you, are watching your cell phone under the table while you're listening to me talk, right? So you have access to technology. The challenge though, for people who are serving, as many of us are, people are unstably housed, some of them don't have cell phones or they don't have access to Wi-Fi, or what they have is like, every other minute you have a little bit of Wi-Fi. And so we said, well, how will we care for these people when they don't have access to the technology that the general populace has? And so how can we bring the healthcare to those spaces? So we piloted a program with another amazing partner, New Hope, to bring telehealth to their residents by bringing in the picture of the robot looking guy there. It's a med pod, and we brought them to 2 of the facilities we serve at New Hope Housing and set up a program that people could come down, engage with a medical assistant who would help them navigate the technology, because there's a barrier there, right? And how do I use this thing that kind of looks like a robot, and engage with a clinician at one of our clinics. We thought this was amazing and innovative. Well, after a few months, we said, gosh, the numbers are much lower than we thought they would be. Let's go in and ask the clients again, how's it going? What's good? What's bad? And they said, well, we want you to lay your hands on us. We want someone to put their stethoscope and we want to talk to a human being and we don't want to talk to them through a screen. We want that interpersonal touch. We had no idea. We thought that, telemedicine would be amazing. And the first people that we did needs assessment with thought it would be amazing. But I guess when they got there, they're like, oh no, we want to actually talk to the doctor. So we spent more time transporting people over to our clinics and actually engaging with the med pods with them. So we said, okay, go back to the drawing board, because the lesson learned there is you have to listen to your clientele and they're allowed to change their minds. Next slide. So we adapted our response and said, okay, it seems as though there is a need to bring the schools to access in-home mental health services by actually having the therapists who were dual therapists and case workers go to their homes and actually perform the screenings, provide the therapy there for them, both at our New Hope housing sites and in some of our scattered site housing spaces. Amazing. We noted that nearly 40% of patients had a demonstrated increase in number of healthy days, right? I learned my lesson. I told the team, I said, okay, the next thing, I know that I'm the science nerd on faculty, all these places, but the next time we do this, we're going to have a measure. Then you're going to come back in 3 months and we'll show the change in the measure, because we're not doing the med pod thing again, where they said, oops, we put these machines there. So we have this measure of HRQOL, which are health related quality of life. And so we follow that over time to ensure that what we're doing doesn't need a pause and a revisit to have more conversation and needs assessment. 43% of the patients have been seen at least 3 times. And the mental health treatment improved the individuals, not just their actual physical and mental well-being, but their perceived physical and mental well-being. And that is a big difference. Even some of you will think, you go to the doctor and the doctor's like, nothing's wrong with you. And you say, something is wrong with me. I told you my right elbow always hurts every time I go like this. And the doctor thinks, well, that nothing's pathologically wrong with you, but you don't feel healthier. They didn't do anything for you. They didn't give you a prescription. They didn't make you feel better about whatever it is that you were expressing as a concern. So having that perceived improvement in health is almost as important as actually improving health. Having that person who can come to you and talk with you in your own space and observe your life allows them to really get to nuts and bolts of, you do feel better. Look, before you couldn't pick up your grocery bag and now you can. Next slide.
So I'll talk a little bit about the COVID response with Healthcare for the Homeless Houston. Some of our experiences, and we talked about this, were actually very different. Early on in the pandemic, the city asked us to be sort of the official testing site for people experiencing homelessness. So we tested mostly at either the Cathedral Clinic near the Beacon or at our Caroline Street Clinic. Like everybody else, our clinicians were frightened in the beginning. We had one incident that we laugh now, but it was not funny at the time. A woman came into the Caroline Street Clinic. She was back in the clinic and she started coughing and everybody fled, including the provider, just fled. And then they got hold of themselves and went back in, and she had pneumonia, not COVID. So it was, just kind of a touch point for us. One of the things I wanted to talk about, and overall, we've to date, we've tested over 1,500 people and vaccinated almost 1,200 people that are experiencing homelessness. So we've done quite a bit. We also did surveillance testing in the shelters to go in to try to see how shelters were doing, and we identified 3 outbreaks that then the city could come in and work with that shelter. The different experience that we had was with telemedicine. We had bought a MedPod, didn't use it with telemedicine, but we had one of our providers, 2 of our providers who were providing telemedicine, and our patients loved it instead of hating it. So what the difference is, Dr. Flash and I haven't figured out, but our no-show rate for psychiatry went down 350%. So it's just a difference in either approach or population, or I'm not sure what, but it was a very different experience than what Dr. Flash and her staff went through. And I think we were going to, do we have one more slide? Okay, good.
And I think this
Oh, yeah.
example that we give of difference is profoundly important. Sometimes as leaders, you look at your own agency and what you're doing, and you look at it in you look at the glass and you kind of focus on here, when you really have to look out and say, what I do in community A might not work in community B, right? And what I do with provider A might not work with provider B. And there is an incredible need for the discourse, lessons learned, but also to listening to the communities and not trying to make them all a one size fits all, but actually recognizing their difference, embracing their difference in a way that allows you to actually serve them and affirm them. And so whether it's the population is more street homeless than unstably housed in permanent supportive housing, or whether it's the corner of the world of Houston with its diversity, race and ethnicity, or their gender identity, or whatever it is, there is so much difference, beautiful difference in our communities, and we need to pay attention to that difference, not try to cookie cutter it, but figure out how we need to adjust what we do to affirm all of those spaces. So as we were thinking about how do we close this out and what are the lessons learned, one of the things we thought we would share is this power of needs assessment and iterative response. Just because you decided that this is the path forward, if a COVID Mack truck crosses in front of you, you pause and you say, okay, well, maybe that isn't the best path, right? And so the ability to pause and say, are we doing the right thing? Have we looked at the measures? Have we set up measures to actually see if things are going well? And have we talked to the communities that we're engaging with, affirm them to have voice to influence what's happening?
So we had an experience like this. Both of our agencies are working with the Housing Authority on a United Healthcare grant, trying to look at health and housing. And we've been meeting forever. And we started going down a path looking at diabetes. And at one meeting, I just kind of stopped and I said, we're going down this path and we have not talked to any of the people that are living in permanent supportive housing to see whether or not they're interested in this path. So we had 3 different focus groups, 4 or 5 different focus groups. And the thing that emerged that was the most salient was social isolation. not diabetes, not hypertension, none of those. It was social isolation. So now we're in the middle of trying to figure out what our intervention is going to be. And then that's what we're going to focus on, rather than what we had started out assuming would be the path that we're going on.
That's right. It was, once we got over the amount of meetings we had to figure this out, it was transformative in terms of how we're going to now approach what's become an exciting project. Before it was just, oh my goodness, another meeting. I'm not a meeting lover, but I am a lover of change and of making powerful impact in community and of reinforcing my perception that health is not just about absence of disease. We like walked into the same wall again, right? Talk only about diabetes when it was the social isolation, which is that broader definition of health. Social and mental well-being are driven in many spaces by social isolation. Healthcare outcomes are as well, right? When there's no one to say, hey, did you take your medication? Or I need a ride to the doctor? Or gosh, I have a handful of pills and I'm just so sick of it. Having someone who can say, you got it, you got this, here's some water, or open your mouth. That helps. So social isolation will help with those other features, but we have to go from a patient-oriented or client-oriented approach. So the next lesson learned was that one size does not fit all. When I talk with other leaders in Houston, I say, you know, I am a very competitive person because I try to be excellent. But my excellence does not outshine your excellence. I believe that we can all be excellent together. That's why I moved from where I was to come to Texas, because I was like, listen, there is so much healthcare challenge here for us to address. There is room in the pond for everyone to have their level of excellence, and there is going to be an imperative for us to work shoulder to shoulder to solve these problems. I can't solve the problems of how health and housing integrate without the wisdom of Mr. Nichols, right? I can't do it without other partners who have the expertise in dealing with the literal street homeless population. So we need each other, and we need to engage in the wisdom of what people who've been walking different roads can share. The third lesson learned, they took my slide away, but the third lesson learned was the power of a pandemic. And I think that that's a lesson for us in many ways that, and I tell my leadership team this often, I said, you know, one man's crisis is another man's opportunity. And so I think we all in this space, in many ways, have all become patients of this COVID, right? And there's one way to look at it, like, oh my God, this horrible thing, I'm so glad I take my mask off and I can go on the plane or whatever I can do. Or you can say, gosh, this is an opportunity for us to reframe how we engage so we can do things in ways that when the next COVID comes by, we are prepared and we know what to do. We can do it more rapidly for a shorter season, get it under control so we can all move on to, you know, barbecues and flying and healthcare face-to-face where you put your hands on your patients. So immense lessons learned, amazing partnerships, and an honor to stand before all of you and to serve alongside all of you. Thank you.
Absolutely.